Welcome, and thank you for joining this virtual panel hosted by the American Diabetes Association in partnership with Roe. I'm Heather Landi, Senior Editor at Fierce Healthcare. We'll spend the next hour discussing the role of telehealth and other technologies when it comes to chronic care management. We'll reserve the end of our webinar to go over questions from the audience, so please submit your questions using the Q&A chat function. Now let's meet our panel. Dr. Barnes, if you could start us off by introducing yourself and your organization, and then we'll move to Amar, then Nathaniel, and then Dr. Shomali.
Hi, everyone. Thank you so much, Heather. Thank you to the ADA and to Roe for having us all here today. My name is Dr. Melynda Barnes. I am a double board certified otolaryngologist and facial plastic surgeon. I'm also SVP of Medical Affairs and Research at Roe. Roe is a digital health platform that's also a telepharmacy. So we have 3 brands. Roman is for men's health, Rory for women's health, and Zero is for smoking cessation. We also have 2 service lines. One is Roe Pharmacy, which is a $5 pharmacy where we have over 500 generic medications, each for $5 a month. And then our other service line is actually a partnership with Gelesis, a pharmaceutical company, for the first direct-to-consumer launch of a FDA-cleared device, which is Plenity, and that's for weight management. Yeah, very happy to be here.
All right, thank you. Now, Amar?
I'm Amar Kendale. I'm the Chief Product Officer at Livongo Health. I joined Livongo when we started the company back in 2014. Coming in with a background in healthcare innovation across a variety of different disciplines, medical devices, pharmaceutical products, and wearable technologies. And what brought me to Livongo was the opportunity to really redefine the care model focused on a person living with a chronic condition in their daily life and bringing all of the technology and services to them in a way that allows for extraordinarily effective self-management as well as connection to the rest of the healthcare ecosystem. We've gone on to build services for people with diabetes, with hypertension, prediabetes, as well as behavioral health needs most recently. And most importantly, we're looking at the whole person, not just a single condition, but really the combination of things that impact a person's management of their health. Very excited to be a part of this panel and discussion, given that care models are changing so quickly, and there's a lot to learn from one another. So thank you for having me.
Great, and Nathaniel?
Yes, my name is Nate Laktman. I am a partner with the law firm of Foley and Lardner. We've been around for maybe 180 years, but I've only been there for the last 16 or so. I chair our national telemedicine and digital health industry team, and we work exclusively with companies, whether it's entrepreneurs and startups or academic medical centers and hospitals or physician groups who want to build and scale virtual care offerings throughout the state, nationally, or globally. So as a result, we get to look behind the curtain of how the sausage is made with a variety of different constituent entities.
Great, and then Dr. Shomali.
Hi, my name is Dr. Mansur Shomali. I'm a practicing endocrinologist in Baltimore, Maryland. I work at a MedStar Health diabetes center. So I take care of patients with type 2, type 1 diabetes, hypertension, dyslipidemia, obesity, all the things Amar talked about. And I feel like I'm spending most of my time with telehealth right now, with only a handful of patients coming live to my office. My second job is that I serve as Chief Medical Officer for Welldoc, which is a technology company that designs software that helps patients and providers with chronic diseases like diabetes. So I feel like I sort of have a foot in each door of clinical medicine and in technology. So it's really great to join your panel today.
Great, well, I'm really excited about this discussion. Let's just kick it off by talking about, what does chronic care management look like for your patients now compared to just a few years ago? And what do you think it'll look like in a few years? Dr. Barnes, can you kind of start us off, and then we'll move to Amar, and then Dr. Shomali, and then wrap up with Nate.
Yes, so I think it's, I always have to remind myself that Roe launched October 31st, 2017. So a couple years ago, there was no care being given on the Roe platform, but in almost 3 years, we have almost 20 conditions. We've treated almost 1 million patients. We've treated patients in every state and in 96% of primary care deserts in the United States. So I can speak to what chronic care management looks like in the future at Roe, and it looks like care that is patient-centric. It's empowering patients to have that one-on-one access with their physician. It's getting rid of the notion of just checking in with your doctor once a year for an annual physical, and more having that daily even, but just like connected care when it's needed. It's knowing that you can reach out to your doctor whenever you have any issues. And it's also making sure that patients are appropriately treated in the venue that's best suited for their care at that time. So what I mean by that is someone who doesn't need to be in the emergency room doesn't have to go to the emergency room for care. They can get care in their home. If they need to go in person, they can go in person, but streamlining and making sure that patients are being able to be treated in their home when they can. I think that that helps not just only for the patient, but also the overall burden of healthcare on society. The more that we can keep people in their home and use technology, then we can save in-person visits, emergency visits for patients who actually need that level of care. So basically, I think, chronic care looks like integration. It's allowing patients to be empowered. It's using technology and remote monitoring devices to give real-time feedback to patients. It's letting them, it's empowering them with content so they know more about their condition, and it's giving them access to their doctor when they need it, or their care team when they need it, so that they're not waiting 6 months, 8 months until that annual visit to address conditions that could have been better treated in real time.
Great. Amar, same question to you.
Sure. So, we've been on a roller coaster or a rocket ship, depending on how you look at it, when it comes to care for people with chronic conditions. When we started Livongo, it was very much focused on a similar problem to the one that Dr. Barnes is describing, which is access to care is very variable. And moreover, for people who are trying to self-manage their conditions, knowing where and how to get that care, or more importantly, when to get that care, has been a real challenge. So what we have spent the last several years doing is building services that start to answer those basic questions. Are my numbers looking okay? Or do I need to talk to a professional? If I need to make changes to my life, what kind of changes are those? Can I make changes to my lifestyle, or do they need to be clinical in nature? And that kind of decision support is something that technology can really serve a tremendous role in delivering at scale. At Livongo, what we've done in the case of diabetes is we provide our members with the connected technology that they need in order to monitor their condition, their numbers. We do this by streamlining a lot of the friction that would normally be there, providing them with devices that have cellular connectivity, for example, and all the test strips that they could possibly need in order to check their blood sugar. But the things get really exciting when you consider what to do with that data and the kind of insight we can offer people once we're seeing real-time data coming in. And what we found is when we do that, we offer those insights, we offer that feedback, people do change their behavior and they start to get healthier. And we've been able to demonstrate meaningful improvement in their clinical outcomes, as well as cost savings that takes excess cost out of the system. So we've gone on to replicate that model now for hypertension and other conditions. Then of course, we started to encounter a very different world over the course of the last 3 months. When it comes to healthcare broadly. But I would say that for Livongo specifically, we've been very well positioned to execute on more or less the same model, where by providing people with those resources at home in their own environment, they've really been able to take control. We see pretty substantial increased usage and adoption of Livongo throughout this period of time. And I know we'll talk more about COVID-19, but it really does reinforce the idea that people need support in their daily life, not just inside the healthcare system as it's traditionally been delivered.
And Dr. Shomali, you're an endocrinologist. So how have you seen care management for your patients change, today compared to a few years ago? And then what do you see in the future?
So Heather, I think, when I was in medical school and medical education really focuses on the transactional nature of a medical visit. And so it's usually solving an acute problem. My back hurts, my blood pressure is high, I have right upper quadrant pain. You get an x-ray, an ultrasound, blood work, and it's very transactional. So as someone who has had to teach himself how to take care of chronic diseases like diabetes and hypertension, obesity, those are conditions that don't fit that transactional approach very well. So, you know, if someone calls my office for an appointment, they might get one in 2 or 3 months. There's a waiting list to see a medical specialist. So, well, you know, that just doesn't work for people. And that's how our system has been built over the last few years. And hospital administrators and practice administrators like it when our schedules are booked. But that doesn't really allow us the flexibility to take care of patients in between visits is when my patients have trouble, not when they're sitting right in front of me most of the time. So in the past, that's the past. So we're really trying to embrace a different way of doing things, less transactional, more supportive, more longitudinal, being able to fit patients in our schedule. My no-show rate used to be high. I practice in an urban area where sometimes my patients can't get a ride to see me. At the last minute, their ride cancels. So they don't make it to my office, but I've blocked half an hour to spend with them. So I'm sitting there not seeing a patient. My patient doesn't get care. And so with telehealth, that doesn't matter anymore. It's okay if they don't have a ride because they don't need a ride. And so I feel like over the last couple of months, my schedule is full from when I start seeing patients till when I finish. There are no-shows, there are no missed appointments. People come in, they get cared for as best as we can. We can't do everything over the video visit, but so it's a really different world, Heather, today. And it just changed overnight, which is really amazing. We've been talking about making these changes for years now, I feel. And then they've just kept the software and the technology on the shelf. And then overnight, we went to quarantine, and all of a sudden, they pulled the software off the shelf, turned the buttons so that they started working, and we had telehealth visits. So it's been a really interesting few months for us in healthcare.
Great. And Nate, looking at the policy side, what are some of the regulatory changes that have occurred that have really helped to open up digital health, both before the pandemic and during the pandemic?
Yeah, I would say we can put them into 3 buckets: licensure, practice, and payment. The most important of the 3 being payment. Although we saw a significant uptick during COVID with the use of digital health, because of an external force, people are afraid of getting sick, both the clinicians as well as the patients. So there would have been a natural reluctance to go in person. A number of these payment changes occurred before COVID. The most significant ones to chronic care management or like for diabetes, for example, I think would be the CCM, the chronic care management codes, as well as the RPM, remote patient monitoring codes. The CCM codes were introduced like 3 or 4 years ago, and the remote patient monitoring about 2 years ago. They were so fundamental because for the first time, the Medicare program, which is usually fee for service, like Mansur said, is transactional, said we're gonna pay you on a monthly recurring basis, right? Per patient per month, which in Silicon Valley speak would be MRR, which all of those entrepreneurs love. And in patient speak, it really would try to put the relationship back in doctor-patient relationship. You, physician, are on the clock throughout the month to look at the patient's long-term care needs. How are you going to do that? You'll harness technology to remotely access the patient's physiological data, toss it into a dashboard, and send it to you at your local command center. In addition, CMS said, you know what, it's too much to expect a single physician to do all of this herself. We will allow some incident to billing so she can leverage her clinical staff to help review and access some of that information, relay it up the chain to the treating physician. I think it's actually an excellent model. We've started to see some adoption in it on CCM, RPM in particular, because you have all these hot rods and Ferraris and really fast technology, which had no gasoline to operate, right? And now they do. With regard to COVID itself, though, the biggest waivers are more transaction-oriented items, like now phone calls and some asynchronous that wasn't covered is now covered. We see licensure waivers, so now doctors can just be licensed in one state, provide care in a whole bunch of states, as well as prescribing. DEA is waived. Controlled substance registration and in-person exam requirements. Some states have done the same, as well as commercial health plans. Keep in mind, though, those are all waivers, right? So they're limited to the public health emergency. They're time limited. Blitz scaling a new company using those, you would really want to exercise some thought, because this is chronic disease you're dealing with. And when those waivers go away, you'll either have to be licensed and compliant operation, or you risk patient abandonment issues if you can't transition them away.
And just as a quick follow-up, Nate, from your perspective, what's some of the changes that took place during COVID, the waivers, of those, which do you think will stick around?
Good question. So HHS has suggested via tweet that it will renew the public health emergency, which is set to expire at the end of this month. But Dr. Andrei Otrovsky, the former chief medical officer of CMS, put a blog article out yesterday which rightly said they haven't yet done so. And it really would be catastrophic, in his opinion, if it doesn't, for medically needy populations. If I had to pick and choose, the licensing waivers are unlikely to stand. They'll eventually go away. The DEA controlled substance, there is a proposed rule that was in the works to make that permanent. So that might be a 50-50, depending upon who is the attorney general post-election. And I think that the CMS-oriented Medicare expansion of coverage will remain. There's federal legislation to make certain, to eliminate the rural and originating site requirements. And then CMS itself has indicated that it's going to continue to remain bullish on expanding virtual care coverage within its own administrative authority. And we will see that manifest either at the end of this month or the first week of August, when CMS publishes its proposed rule on the physician fee schedule.
Right. Great insights there. So how has COVID-19 changed the conversation around innovating around chronic care management for the panelists? And how have you made use of the surge in digital health and policy changes? Dr. Barnes, do you want to take that first?
Sure, yes. I think, it's pretty much what we've been hitting on from the beginning, which is that I think some of the issues with telehealth adoption has been resistance from physicians and health systems that did not have telehealth offerings. And overnight, those physicians and those health systems had 0 patients, which, hate to bring it up, that also meant they had 0 revenue. And so all of a sudden, some tool, digital health, that was, they were very skeptical of or didn't want to use, became their lifeline to connect with their patients and to continue providing care to their patients. And so I think that has been the biggest thing, is now it's not a handful of doctors who work in tech or who work for companies that are in the telemedicine space that are speaking to the benefits of telemedicine and speaking to the benefits of remote patient monitoring and being able to have continuous communication with your provider. Like Dr. Shomali mentioned, it's not just, I'll see you every 3 months. It's, you can call me, you can text me, you can video chat with me once a week if needed. So now that we have more buy-in, I think, from mainstream academic institutions, big health systems, we have more people thinking more about how do we keep people in their home. The providers don't want to get sick. The patients don't want to get sick. We need to keep people in the hospital who have COVID. We see that triage and separation of patients who need to be treated in different venues of healthcare delivery. So I think that has really helped to push some of the regulatory changes that Nate is talking about. And really, we're all kind of on this united front of how do we pay for the physician's time? So that's changes on the payer side, regulatory with licensure, and also the providers are now have bought into that. And conversely, now the patients have as well. Instead of saying, oh, I don't know, can my doctor really take care of me through a video chat or through a phone call? Everyone is really rallying behind this. And I think a lot of patients and a lot of providers are saying, wow, this is actually great care. I'm actually not just somewhat satisfied, but surprisingly more satisfied with the experience that I'm having. And to Amar's point, like if you have that, connected devices with something like diabetes and your physician or your coach is able to see your values and provide that real-time feedback, that's a lot better for patient outcomes than keeping a log of 3 months of finger stick measurements and then getting your insulin changed and titrated based on that when you can do it almost in real time. So I think the conversation has changed from skepticism to how do we actually use this wonderful tool? How do we put gas in the Ferrari? And then I think for us at Roe, our big thing is just how do we provide value to patients? We're lucky in that we're 100% cash pay. So we do not have some of the restrictions and constraints of dealing with what the payers are going to pay for reimbursement. Our only customer is the patient. And so when we're no longer providing value to them, they will vote with their feet and go someplace else. So we are always continuously obsessed with what does the patient need right now? And that was one of the reasons why we launched the first nationwide free telehealth assessment for COVID-19. People were scared. People wanted to know, what are my risk factors for this? Am I high risk, medium risk, et cetera? And so providing that to our members and just to anybody in the country was really important to us. And that's really how we think about what conditions we launch next, how we optimize our electronic medical record, which we built ourselves. And we're very proud of that. And I know we'll probably touch on technology, but building an EMR that is patient and provider centric, not billing centric, also changes the way that we can really provide value to patients and providers.
Right. Now, Amar, same question, how has the conversation changed and how is Livongo taking advantage of the policy changes?
Sure. Well, I mentioned already some of the behavior change we've seen among our members, which is to say they're adopting Livongo more. So we're seeing very good response when it comes to new membership in Livongo. We're a covered benefit. We're offered through employers and health plans to millions of Americans. And so given that there's this high risk associated with chronic conditions in combination with COVID, that as that awareness grows, we've really found that to be a very helpful way to describe how Livongo can help. But double clicking into that, I'd say that overnight, to Dr. Shomali's point, Dr. Barnes' point, we've seen this flip from 90% in office to 90% telehealth. And you can imagine in that telehealth visit with your physician, if there isn't any data to work with, it's a very challenging care model. And I think that has really solidified the value of remote monitoring in this context. But probably more important than remote monitoring is this question of when you do have data that's being collected in the real world, when is the right time to reach out to your physician? And when is the right time to self-manage and care for yourself? And so there's some very interesting phenomena we're observing there. An example I'll share is with regard to stress and the mental duress associated with living with a chronic condition. One of the things that happens when a person checks their blood sugar on a Livongo device is they let us know how they're feeling. And one of those tags indicates that a person's feeling stressed. Well, it turns out that there's a few things we can do in those cases. About 55% of our members are hitting that button right now in this time of COVID, that they're feeling stressed. And what we find is this is correlated to a higher incidence of diabetes distress, which makes it harder to manage the condition, a lower measure of diabetes empowerment, and then clinically we see in association with this higher stress, higher insulin use and poorer glucose control. So what we're really starting to find is that there's more of these phenomena that might be latent or missed in an unconnected world. But if we can really foster this consumer-directed virtual care model, we'll be able to uncover a lot of these phenomena and then direct people to the right kind of resources. So what we've begun to do is, in the context of mental health as an example, is direct our members to those resources that can help them to self-manage or escalate them to a telehealth provider who's able to provide mental health services. So that's been a big initiative for us. Mental health, as I'm sure everyone on is aware, is already an epidemic in America, but I think we should all anticipate that with COVID, we're going to see that grow. And the need for a holistic model that really addresses both physical and mental care is going to become an imperative.
Right. And Dr. Shomali, you work at a health system. How has the conversation changed about digital health amid the COVID-19 pandemic?
So I was kind of smiling when Amar said it flipped from 90% in office to 90% remote. In our practice, we were talking about using telehealth, and we even had a digital health platform that the IT people were integrating into our systems. but no one was using it. And then we went from 0% to 100%, and now we're sort of 80, 20 maybe. So there was a learning curve. We had to learn how to connect to our users. Because of the CMS codes, we prefer to use the telehealth, the regular E&M codes with a G modifier. Nate, I don't know if you're going to talk about those at all, but so we try to connect with a video connection to our users, to our patients, because number one, because that's what the system recommended that we do. Number two, I think it's better to actually see the person you're talking to. And because a lot of my patients have diabetes, trying to figure out how to get their data while I'm talking to them. And in fact, sometimes I feel like having their data may be more important than having them in the office without their data. And so we've been talking about how to get the visit done, how to technically make the connections, what happens if the video doesn't work and we have to convert it to a phone call, what code do we bill for the phone call versus the video visit? We had to learn all of those things. And the nice thing is we had people in our system who sorted all those issues out and told us or explained to us what to do. So it's been a lot of technical challenge sort of transitioning to this new way of doing things. But now it's like the norm, right? It's the new normal. We don't even think about it anymore. In fact, when a patient comes to see me in the office live, I ask them why. Because, they're better off sometimes staying home. I have patients who are in their 70s and 80s who have diabetes and obesity. These are the patients who have the highest risk for getting sick from COVID-19. They're the ones that sometimes still want to come in. They're kind of old-fashioned that way. A lot of my younger patients, they actually don't mind staying home. So it's almost the opposite sometimes we see of what we actually want to happen.
Right, okay. And Nate, from your perspective, how do you think that the conversation has changed just in the last few months in terms of provider adoption and patient adoption?
Well, yeah, I mean, I think we've seen it's an external event, right? COVID-19 that forced the hand of what was naturally already occurring. And we saw some upticks in virtual care use during hurricanes or other environmental disasters, where some of the DTC telemedicine companies stepped up and offered not just medical, but behavioral health and mental health consults to people who were in affected areas. So I think that this was an acceleration of what would be an inevitable or natural evolution, not unlike banking. Like, who goes to an in-person bank, and who's even going to go to ATMs these days to get hard currency, right? People are comfortable making significant financial transactions, life transactions. They buy mattresses, they buy shoes, they buy houses and cars, things that even 5 years ago it would have been unheard of to buy online without actually touching and feeling and experiencing it. And that's just how people are getting more comfortable to buy and consume, so to speak, services. And medicine is no exception. The proliferation of technology advancements, smartphone, broadband, it's actually making this possible. It's not singularly reimbursement rules or doctors, but it is just the change of how e-commerce has affected our country. And I think it's important that doctors as caregivers speak in the language that their patients as consumers are comfortable speaking in as well. What Mansur is also really touching on is an important aspect. Sometimes audio video is appropriate, sometimes in-person is appropriate, but the use of additional data, right? Whether it's derived from at-home tests, labs, RPMs, wearables, or amalgamations of an AI-driven assessment of the patient's pre-existing medical record can really augment the physician's ability to treat the patient in much better ways than just even, this is the first time I've seen you, I'm an urgent care walk-in and we're just talking with each other. So policy is intended to drive that, but I think more so it's been the consumer direction that COVID has accelerated.
Right, okay. And there's kind of just a general consensus, telehealth is here to stay, digital health is here to stay. And let's talk a little bit about how you measure the success and the value of digital health. As digital health has evolved, is there going to be more pressure on digital health solutions and digital health companies to have evidence on how their solutions impact patient outcomes and healthcare costs? Dr. Barnes, what are your thoughts on how you measure the success and the value of digital health solutions?
Yeah, so for Roe, we look at whether or not patients come back to us. Do they stay with us? I think that, we started off with a lot of conditions that were high pain point lifestyle conditions. And what we noticed is that we were essentially reconnecting people to the healthcare system that had not seen a doctor and really felt even skeptical of wanting to get their care in person. And so by bringing them back into the healthcare system and helping to help manage some of their conditions and knowing that they have to pay out of pocket for that, kind of what I was discussing earlier, our outcomes we see on a month-to-month basis, pretty much, like how many people are coming back, how many people are interacting with their physician, exchanging messages, how many patients are being seen for other conditions than what they initially came for. We also started a clinical research program at Roe, and so we have both peer review research and also research that we put out that we like to say we want to get it out into the world faster than the peer review process. So on our Medium page, we have a research and insights section where we talk about, how broadband affects the utilization of telemedicine in the communities that most need it, but have the worst broadband. So sometimes mandating things like video actually hurts the people who would use telemedicine because they don't have the broadband connectivity to do video. But if it was asynchronous, they could still connect with their doctor. We also published our study on the fact that we've seen patients in 96% of all the primary care deserts in the United States. And so our outcomes are really like real-time value add to patients. But we know that in the long term, we definitely will be doing more peer review publications looking at the outcomes of the conditions that we treat. Mostly because we know that we're probably the largest provider of care for the conditions that we treat. We're in all 50 states plus DC. And so we feel like there's a lot that we can contribute to the medical community about things related to efficacy of treatment, side effects, comorbidity effects on other conditions. And so that's more things to come for us. But I think bottom line, being cash pay, is that our outcomes are linked to how, whether or not patients continue to get their care from us.
Yeah, right. Great point. And now, Amar, what are your thoughts on what's the most effective way to measure the success and value of digital health?
Yeah, so I can echo some of Dr. Barnes' comments here in that, ultimately, none of what we do matters if members don't use it. And so, certainly that's the very beginning. And in this world where consumer sentiment has really raised the bar for experiences, the expectation is that what you use for your healthcare is just as good as what you use for e-commerce or for a number of other things that you might do in your life as a typical consumer. So that bar's gone up, and we need to meet it or exceed it. And that's just table stakes so that we can actually deliver the services that then are intended to drive clinical improvement. When we built Livongo, we did take this approach of making sure that we were instrumenting clinical outcomes right from the beginning. So as we think about some of those core behavioral feedback loops that we cared about, and the reason why we gave people a connected blood glucose meter, of course it was so that we could help them to make changes in their behavior. But the signal that we were collecting is fundamentally a clinical signal. It's a measure of your glucose control, which is a great measure of your management of diabetes. And the same thing's true for our other services. So inherent in our program, we're measuring clinical outcomes routinely. We're using that as a basis to drive improvement. And that ultimately is really what our members care about. They want to get and stay healthy. And as long as we can continue to focus on them by wrapping their experience around with this clinical measure, as well as others that we bring in from other sources, then we can be confident we're on the right track. And every bit of advice we give is virtuous and is going to result in better outcomes. There's also another stakeholder here who is our payer. And the other place where we are accountable for delivering results is in terms of cost savings. And I'd say it's those two things together from a payer's perspective that matter. So cost savings, but similarly in a clinically virtuous model. So when we drive cost savings, it has to be while we're also making people healthier. It can't be by restricting care or reducing what people have access to. And so we hold ourselves to that standard as well. And I'd say that's really been the basis for how we've built our flywheel and why our results have been getting better over time. It's because we're able to measure directly inside of our system whether or not that core clinical measure, improvement in clinical outcomes, is really happening or not.
Right, okay. And Dr. Shomali, as you mentioned, you wear two hats. From a health system perspective, how is the value and the success of a digital health solution measured? You need to take yourself off mute.
Thank you. The way that I feel about that is that once our clinic closed because of COVID-19, we weren't able to see patients, we weren't able to bill for them, and we weren't able to take care of them. So even before we had the billing codes programmed into our EMR system, our leadership said, let's do the most important thing and take care of the patients first. We may not know how to bill for their care, but we need to take care of people. So immediately we started doing that. And so it was a matter of, can we actually take care of people in a crisis? We weren't thinking of, is this better than the old way? We were thinking of, how do we just keep our services going? And then our IT people and our billing people went in and they smoothed out the technology, and they built the billing code so I can now sort of see my patient, bill the appropriate visit, do all those sort of important things. So I really value the leadership team that actually said, let's take care of the patients first, and then we'll figure things out as we go along. And that's essentially what we did. But after the crisis is over, I think we're going to have to try to make that case. So I'm involved in a committee that's sponsored by ATTD that's really looking at the value and the effectiveness of virtual care. And we're going to sponsor a study and make recommendations on this internationally. And I think that's going to be really important. We actually have to show that virtual care is as good or as better than traditional care. And it's not just about patient satisfaction. Like, my patients tell me what their blood pressure is on their home self-monitor, right? But is that monitor accurate? Maybe it's more accurate than just getting your blood pressure done once every 3 months at the doctor's office. But there are all these questions we have to answer. What's the disadvantage of me not being able to examine my patient with my stethoscope, do their foot exam, feel their thyroid gland? I can't do that over the phone. So how safe is this in the long term? And what care can we deliver virtually? What requires an in-office visit? Those are all the questions that we're sort of deliberating. During COVID-19, we actually haven't acted on those issues because we're just struggling to deliver the care. But moving forward, we have to answer those questions.
Right. Great points. And Nate, how do you see the efficacy and the value of digital health? How should it be measured? And should there be a strong focus on the impact on costs?
Yeah, I don't think cost savings should be the singular determinant of whether or not digital health is a success. Of course, it has to be clinically appropriate. It has to be meaningful for the patients and the clinicians. I think it has to be scalable so that these models or tools aren't so esoteric that they can't easily be replicated, copied by others to allow more patients to do it. But I think what it's just gonna happen as part of the change in the tenor of an in-person localized practice, which by definition will have throughput and capacity volumes, to using the technology to expand the footprint of the clinicians. I also think that we can rate, for example, telemedicine digital health companies on their efforts to treat patients who don't otherwise, who aren't usually the first adopters. Oftentimes, health technology is for the healthy, wealthy, or the worried well, and it leaves aside people who are low income, or people of color, or people who are not Silicon Valley insiders playing with like really fancy toys. And I understand that part of the process is we need to hone and refine and develop these. But I would point out that all 50 state Medicaid programs offer coverage for telehealth-based services, and Medicaid is primarily like low-income type of program. In addition, when you talk about the Medicare program, currently CCM and remote patient monitoring, they have waivers on copays, so that even if you're a Medicare eligible patient and you are low income, you can enjoy RPM and CCM programs without paying that 20% copay. That is something that might be made permanent. In addition, the technology itself, Medicare pays for it. So the patient as a beneficiary doesn't have to be wealthy and afford a high-tech smartphone or whatnot, because that will sort of be a line item expense on the physician's practice side that Medicare pays the physician for. And in terms of understanding how to even use the technology, there's a separate code that Medicare will pay the doctor so that she explains to the patient, here's what the device is, here's how to use it, right? And educating the patient on it. That's part of the whole package of RPM services. So I do think, at least from a government perspective, I am proud how some state Medicaid programs and CMS have taken these steps to be very aware of financial implications and limitations. It goes hand in hand with the elimination of rural geographic restrictions for telehealth. There are people who live in cities and urban areas who also need healthcare, right? Who also have access issues. It's not just geography.
Right. And that really kind of touches on a question that we got from the audience, which I think is a great question and was something that we were going to touch on in this discussion anyway, but asking about the, very often there's a gap between technology, literacy, and availability in lower income patients and communities of color and their white, middle to upper middle class counterparts. For the three panelists that are from digital health companies, how are you evolving your services and offerings to better meet the needs of this segment of the population who so often disproportionately struggle with chronic conditions? Dr. Barnes, do you want to pick that off first?
Sure. Yeah. I think one thing is that when we do look at things like costs, or let's take a step back and let's just start with whether or not someone has health insurance or not. So you do not have to have health insurance to be seen on the Row platform. I think that's number one. Number two, if you don't have health insurance, the cost of seeing a doctor on the platform is $15, and that's oftentimes waived. So we kept the cost lower than the cost of the average copay. So whether you have insurance or not, ideally it's something that's in your bandwidth. Second, then would be access. So to Nate's point, which I love that you brought this up, access is not just related to geography. You have patients, I'm in New York, we have patients who live here in New York who are surrounded by hospitals, but they cannot get there because they are a gig worker. And for every hour they take off to wait in the waiting room, that's money that goes from rent or food for their kids or for childcare. So they're going to prioritize working over going to the doctor. By allowing patients to see a physician from their phone or their computer, we are giving them more access to healthcare and empowering them to not have to make those decisions. We see just as many patients on the Row platform Tuesday at 2 a.m. as we see Tuesday at 8 a.m. And we see that patients that are in that sort of working age demographic are using the platform all hours of the night. People who are maybe in the more retired demographic are using it more in the standard business hours. But the point is that we are trying to meet patients where they are, which means that you don't have to have a job. You don't have to have an employer-based health insurance. The cost is, we try to keep it affordable. We have access 24/7. You can message your doctor 24/7. You can go through an online visit 24/7. So really trying to think outside of the box, or what are the traditional access points. We see patients, again, in every state. If we look at zip codes, our patients are not, if we use zip codes as a proxy for socioeconomic status and ethnicity, our patients are not just in wealthy Silicon Valley or in wealthy areas of New York City. They are all over the country. They're in rural counties, they're in urban counties, and they're in urban counties that are predominantly populated by Black Americans or people of color. And so we can see that all of the different avenues by which we try to increase access really help. And that's with cost, that's with time, and being able to see physicians around the clock, and also not mandating insurance.
Right, great. And Amar, what is your take on that? On how can digital health help to address health disparities?
Yeah, so I think there's some really important points around certainly accessibility to the technology in the first place. And that's been an important factor for us. things like test strips, which people had to pay a copay for, was a big inhibitor, and if you have to pay for your test strips, you're just not going to test as often as you might if those things were simply paid for and covered. So we started sort of at the bottom of the pyramid from an access perspective to say, what are those essentials that everybody needs just to do the basic work? And so we ensure that everyone who joins Livongo gets test strips for free, as many as they need. They get a meter for free. They don't have to pay any connectivity charges or anything like that. So that creates a baseline. The next thing I'd say really starts to kick in from a design perspective, which is to say, how do we actually make sure that this service can be used by anyone, regardless of their tech literacy or their educational background or their financial circumstances? And that has been a big factor as we've thought about the way the program works. And so, for example, if you don't have a mobile phone, no problem. You don't need to ever download an app in order to use Livongo and benefit. If you don't even have a cell phone, no problem. Livongo still works. And I think those are things that are important recognition of the fact that many people are limited in their ability to make use of those technologies that we often consider to be omnipresent. And it might be because you're on a data plan that limits how much data you can access, or maybe you just have voice on a cell phone. These problems start to become really manifest in the senior population. And our biggest area of growth is in Medicare. And it's exactly what we're starting to see, that retirees don't have that comfort with technology that many of our employer base does. And so it's really caused us to think differently about how to design and contour the service in order to be personalized for that demographic. But it's one that's growing very rapidly for us, and that's given us a great chance to learn and adjust. I think we're going to expect, just like we do, again, in all the consumer parts of our lives, we're going to expect to be treated on our own terms. And I think that idea of meeting people where they are is something that technology has shown itself capable of doing in many other aspects of our life. It's just been slow in coming to healthcare. And so that is a big part of our opportunity. You're on mute, Heather.
Sorry about that. Dr. Shomali, how do we ensure that the use of technology doesn't actually widen some of the gaps?
Oh yeah, that's a great question. It's actually not so easy to answer, but I think Dr. Barnes and Amar touched on it a bit, which is accessibility. So we want to make sure that the technology is usable, and the products that I've worked at Welldoc are FDA cleared. They need to have usability studies done before they can be cleared. They're multilingual, so if a user's phone is working in Spanish, the software functions in Spanish. And in a pilot we did in New York City with New York City Health and Hospitals, essentially about 40 or 50% of the users use the Spanish version of our software, and it's device agnostic, so they can work with any device, any wearable, any meter. They don't even need to use their phone. They could use a desktop. There's a lot of things we can do to try to make sure that there isn't a worsening of a technology gap. But what we've also found, which I think is really interesting, is that the most engaged users we have are the over 65 population. It's very surprising. I mean, people said when we first started doing software is that, older people, they're not going to do it. And in fact, that's been a myth buster for us. Our seniors are among the most engaged users of our chronic disease management software. Now, in my clinical practice, I do have to say that I have trouble sometimes connecting on a video call with my patients. And so some people they just can't do it. And I end up stopping the video visit because it's not working, and then making a phone call. So a lot of my seniors, they actually can talk on the phone easily because it's something they've grown up with all of their lives, but they can't do a video call on their phone. And others can. So I think, as Nate said, I believe we need to be able to have technology options for those who are comfortable with certain technologies and those who are not comfortable with certain technologies. And I think that's very useful to have multiple platform options.
Right. And Nate, is there anything you'd like to add on this topic of, addressing health equity? I know you kind of already touched on it a few minutes ago.
Well, I mean, it's not in terms of the technology. It's not just Dr. Shomali and Dr. Barnes that think that there should be a broad array of techs available. It's the medical boards as well, and the payers. What we've seen even before COVID was a continued change to be sort of modality neutral under state law, saying, yeah, we will defer to the doctor's independent professional medical judgment. Standard of care must be met, but we will not dictate that it must be audio video or it must be interactive audio so and forward or a pure async. The most important part is that do you have the adequate medical information and have you sufficiently digitized the doctor-patient relationship to make this safe, meaningful, and relevant? And I really would applaud a lot of the DTC and the cash-only retail medicine companies, whether they're telehealth or a combination, because they are in some regards showing to the rest of the medical establishment, look how much differently we can deliver care, right? And how much more cheaply we can deliver care when we go to a retail medicine play by eliminating the overhead, of which lawyers are one, associated with like third-party reimbursement models. There's an incredible amount of administrative overhead that can be eliminated if in a cash-only retail medicine play.
Right. Just a reminder to our audience, as we're getting into the last like 10 minutes, if you have any questions, feel free to use the Q&A chat feature to submit your questions. I think this is a question from our audience, and probably a great way to kind of wrap it up. But looking ahead, let's say 5 years, what do you see as kind of the future of telehealth and digital health? And, specifically, how do you see your platforms evolving? Dr. Barnes, can you take that first?
Sure. I love talking about the future. At Roe, our goal is to be a patient's first call. And what that means to us is that when I like to think of it as, I'm a physician, and when my friends are experiencing something, no matter how small or how big, the first person they usually reach out to is me, and I'll get a text message, whatever, whenever that is, I'll respond. I can help walk them through that healthcare navigation of what they need to do next. Sometimes I can provide care to them, and sometimes the care that I provide to them is giving them reassurance or connecting them with content or connecting them with an in-person provider or just recommending some guide as to how they should go about getting whatever they're concerned about evaluated. And I think that at Roe, our goal is really to be, a complement to in-person providers, is to meet patients where they are, be able to provide as much care in the home and digitize that patient-physician relationship so that the patients who are 70 and have, they take 10 medications and they have multiple comorbidities, they can be seen in the doctor, and the doctor visit is not 7 minutes. It can actually be 20 minutes, or it can actually be the 30 minutes that Dr. Shomali sets aside for his patients, because the younger, healthier patients are being taken care of online, and the patients who are in person are being seen there because they need to be seen in person. The idea that we have this nice fluid connectivity between digital care and in-person care, I think that's where the future lies. I think that we need data portability. I won't even get into interoperability, but the fact that we need patients to be able to carry their data, what medications they're taking, how often, what are their allergies, what was my blood pressure yesterday when I saw Dr. Shomali, what was my finger stick when I used the Livongo device. They carry that with them so that if they decide to come on Roe to get treated for seasonal allergies, we have access to that data as well. So I think there's a lot around empowering the patient, then also empowering the provider as well. So how many women are able to still stay practicing medicine because they don't have to decide between going back to work and taking care of their family? They can take care of their kids on maternity leave, and they can also take care of their patients using digital health tools. Same thing for working fathers or single parents. And then also for patients, as we start giving them more power, they will be able to go to physicians who they feel like are culturally competent, culturally sensitive. They won't have to go to doctors who they feel like are biased against them and have worse outcomes just based on the color of their skin. And I think that technology and digital health can really help with that, because at least at Roe, patients are going through an online visit. We take a lot of time to make sure that our questions are framed in a way that addresses any unconscious bias that we may have. So we have multiple people read them. We're thinking about gender bias, removing that, sexuality, removing that, and really, again, meeting patients where they are, and then allowing patients to feel like there's a connection between them, the platform, and their provider. And again, I think that that's huge, that patients can have 24/7 messaging and access to their doctor. It allows them to really develop that relationship more than just coming in person. I'm there with them for 7 minutes and then I leave. So data portability, the ability for patients to vote with their feet, of course, devices. The more technology that we have connected, the more that providers can do. That means that patients can stay in their home. And I think there'll just be widespread adoption. There'll be a lot of patients who their first call will be to the digital provider, and they'll be able to help with healthcare navigation, taking care of the patient in the home, prescribing medications, ordering labs, and then referring them in person when needed.
And Amar, same question. What do you see as the future of digital health, and how is Livongo's platform going to evolve?
We're starting to describe it as consumer-directed virtual care. And what that means to us is some of the comments that Dr. Barnes made are certainly pertinent. Consumers are taking more ownership and control and responsibility for where and how they consume healthcare. And that's a trend we see is accelerating. In order for it to work, though, some of these building blocks need to be in place. And we are starting to see this great willingness to adopt telehealth. I believe that's going to be a permanent change. That's a behavior change that's going to stick. And it's a combination of the workflow factors that Dr. Shomali was talking about, as well as the economic factors that Nate was talking about. So great, we have these structural kind of fixes, to the telehealth side of the equation. We also have this set of remote monitoring capabilities that people are starting to make use of out of necessity in this time of COVID when you're really trying to care for yourself at home. But it's really driven this adoption phenomenon that similarly is a behavior change. And those are the things that would normally have taken us decades to arrive at. And particularly for these lines to cross, where both of these phenomena are happening at the same time, that's what makes this an unprecedented moment in healthcare. So as I play this forward, what really becomes important in this next phase is connecting the dots and making sure that the whole model works, that not only is there remote monitoring, not only is there telemedicine being practiced, but all of this is knitted together in a model that is paid for, that is sustainable from an experience perspective, that's accessible to all, which means that coverage really does have to be broad. And so that's really been our focus. Particularly over these last 3 months, as we've been thinking about those strategic moves that are going to help us to address more Americans and folks across the world. In part, it also means expanding our purview to consider the other challenges that people face. We started, as I mentioned, in diabetes. We've expanded from there. The reality is people are living with a multitude of chronic conditions in various different combinations. But really what we want to do is help people, not conditions. We want to help people, and they may have any number of these conditions that we need to support them with. So that's given us a lot of insight into how we should build our roadmaps, expanding the scope of conditions that we cover, but fundamentally focused on each person and making sure that they have what they need in order to self-manage successfully.
Dr. Shomali, how do you see digital health evolving?
So I echo a lot of Amar and Dr. Barnes's points. Each of us has a role to play in the healthcare system. There's a role for the healthcare provider, for the insurance plan, for the case manager, and for the technology. We're going to invest a lot in the AI, the artificial intelligence, the computer intelligence, because I feel like there's not a smooth transition of when a patient can self-manage to when the patient needs to seek out the healthcare provider's help for a prescription change. Some things people can help themselves on their own with a lifestyle adjustment, food choices, activity, medication taking behavior, and we can coach all that. But the systems need to be smart to say, hey, it's time to see your healthcare provider now, because this isn't something you can fix on your own with an adjustment in the way you take your medicines or your food choices or your exercise routine, that sort of thing. So I feel like the future will be smarter AI that's going to actually connect the patient to the right provider at the right time. And in fact, if it's an insurance issue or a social determinants of health issue, maybe a social worker would be better than a physician in that situation. And how do we have like a computer triage system that detects sort of where the user needs to go to sort of get better? It's not always call your doctor or call your healthcare team, because sometimes things are better managed in other ways. So this holistic approach, the AI is not smart enough yet to implement. It's kind of choppy, and we're sort of just at the beginning of building these routines. So the algorithms will get smarter, and I think it's going to result in a better healthcare experience overall.
Right, that's really interesting. And Nate, so what is your take on the future of digital health?
It's going to continue to grow. We're going to see policy open up. Already 42 states have laws requiring commercial health plans to cover service delivered via telehealth. That's going to continue to expand. We've helped write some of those laws. So I can tell you that there's still more interest in having states expand telehealth commercial insurance coverage. At the same time, we'll see more state medical boards changing to become modality neutral and technology neutral. The only caveat I would say is as this continues to grow and we see more conditions being treated virtually or in an entirely virtual setting, it is incumbent upon the clinicians, the physicians, and the companies that they work with to make sure it's being done safely and appropriately. Because it's not just like a demo project or a pilot or like, oh, this is kind of a fun thing. This is healthcare being delivered through technology. And I think as use expands, so will expectations, not just of patients, but of regulators, to have this a bona fide, meaningful experience, not just sort of like a drive-through substandard internet prescribing. Nobody wants to see that from a policy perspective. And bona fide patients and doctors don't want that either. So I think companies should continue to iterate, challenge themselves to say, we're doing something great. How can we do it better, right? How can we continue to evolve and enhance this digitized doctor-patient relationship? That will put them in the best place to bring telehealth forward.
Those are great points. And with that, that is really all the time that we have for today. But I'd like to thank our panelists for joining us and sharing their really great insights, and thank you to the audience for attending. And also thank you to the American Diabetes Association and Roe for hosting this virtual event. And so have a great day.
Thank you.
Thank you.